Hey everyone, come on in, take a seat. We're gonna have a good chat here. Okay, so this is synthetic by design, biologic by outcome, a bioinductive scaffold approach to stronger tendon healing without complications. And I'm Spencer Stein from NYU Langone. Got it. Okay, disclosures are on the Academy website. So the deck is stacked against healing. Why? Because of a lot of non-modifiable risk factors. Patient comorbidities, poor native tissue quality, high mechanical loads on rotator cuff repairs, limited vascularity, and there's really an early window here where the rotator cuff is vulnerable, and we'll speak about why on the next slide here. So re-tear rate is high. It's 15 to 20% in rotator cuff tears. And actually, that's probably an average. It's been shown to be up to like 80, 90%. So if you really look at it, 50% of those tears, so at least half of re-tears occur before 3 months. At the same time, by 3 months is when healing probably occurs. So what does that mean? There's a race between healing and re-tear. So everybody, where does the re-tear happen? Where does re-tear happen? It happens from tendon pullout, right? That's what everybody says, from suture pullout of the tendon. But is that really what's happening? Or is it that the tendon's not healing, and then from recurrent repetitive stress, there's tear at the suture interface? And I put the Sugaya type 3 progression because Sugaya types are MRI classifications of rotator cuff re-tear, and type 3 is a thin tendon. And so even if you have a thin tendon, in early 3-month postoperative MRIs, those can progress to full tears. And full tears are not good. So it's a race between healing and re-tear. So the biologic environment remains the weak link. Why? Because incomplete healing at the tendon bone can lead to disorganized scar tissue, which is just weaker. And we're not just carpenters anymore, right? Everybody's like, oh, orthopedists are carpenters. We're not carpenters anymore. We are biologic. We are biologists, really, and we want to improve we're gardeners. We want to improve the interface healing and the biology at the repair site. So why would we expect less than optimal healing with scar tissue? Although healing failure does not necessarily translate to poor clinical outcomes, right? So even if things re-tear, people do okay, but overall there are poor outcomes and decreased function with re-tears. So, you'll see a patient, they have a re-tear, and they're like doing okay, but overall in the grand scheme of things, you want to have the best possible long-term outcomes to the patient. And that's why we need to increase healing at the enthesis, at the repair site. So what are some new technical considerations we can try? Well, really augmentation is the hot topic. And an ideal augmentation technique would be efficient, adding little complexity to the case. It would be economical, not adding a lot of cost to the procedure and to the hospitals. It would be evidence-based with good, robust clinical research and background. And it would be essentially established, like something that's been around for a while. And the jury's still out on which patch is the best, right? So probably the most studied patches are the dermal allografts and the collagen-based patches. So dermal allografts is, right, what it says. It's skin. And the pro is it has strength to it. Like if you felt dermal allograft, it's very strong. The con is it might not incorporate completely. It's limited to onlay. So most of these patches or augments, you're adding to the top, really all of them. You're adding to the top, right? Does that make sense? You have an undersurface tear, you're adding a tendon, you're adding a patch to the top, and that's going to thicken the tendon? I'm not sure. Collagen-based patches, they're limited to onlay. Is there inflammation? Probably yes. Why is there inflammation? Nobody knows. Is it the staples? Some people say it's the staples. Is there still DNA in the bovine patch? Probably yes. And it's costly. So let's break this down a little bit. The dermal allograft, yeah, it's been studied. There's studies showing that it has some favorable outcomes, right? You can find a study to show anything. But here was one case report where at 70 months post-rotator cuff repair, the acellular dermal allograft failed to remodel and to have normal tendinous appearance. So this is not what a rotator cuff looks like. This is skin. The collagen patch. Okay, again, it does have there are some good outcomes on it. And if you look, it's probably the most studied. But it's mixed evidence. The impact of patch augmentation on healing was not observed in one study. Here's another one. Augmentation with bioinductive patch and ACP, PRP, failure rates were comparable. There was no significant improvement. A greater proportion of patients who received bovine collagen underwent reoperation for inflammation and stiffness. And we've presented at this academy ourselves a paper showing about 15 to 20% stiffness rate after collagen patch augmentation. So we were cautious with that. So what is another option? And this is what we're getting to, right? What if we could move beyond scar-mediated healing, regain control over the biologic environment, restore structural stability as well, and guide reproducible and long-term patient outcomes? That would be ideal. So we're here to speak about the rhodium wick. The rhodium wick is a synthetic microfiber matrix, and the rhodium wick specifically is different because it's an enthesis-based augmentation. It goes between the bone and the tendon. It can be used inlay or onlay, right? And again, inlay being like between the rotator cuff and the bone is how I found it to be most useful. It retains 400% of its weight in blood. So basically what it's doing is retaining bone marrow elements. We know that vented anchors are better. Why? Because vented anchors allow like bone marrow to seep through and integrate into the rotator cuff. So if we can do that, if we can maintain blood there and marrow elements there, likely that's going to be an improvement, and that's what the folks here at Rhodium have been able to do. And it's applicable to really any tendon repair. Really, I mean, if you look at tendon repairs, besides rotator cuff, they're kind of big problems. Achilles does okay. Patella tendon, yeah, they heal, but patients can be weak. They can have some extensor mechanism lag, and they re-tear too. They've also come out with a biochart. So usually, and we're going to speak about exactly what's in this wick, but they have an ability to do an onlay, which is very simple. You go right down your sutures, and it's adding medial lateral coverage, so expanding your coverage. I think it's probably expanding, allowing the forces to kind of expand over your rotator cuff, so you're not getting such punctate forces on the rotator cuff. It's fast, it's easy, and it fully resorbs. And again, what is it? It's all synthetic, so it's not collagen from bovine, there's no DNA. It's PGA and PLCA woven together. So what is PGA and PLCA? They're essentially organic acids. They're made of glycolic acid, lactic acid, and caproic acid. All right, and these fibers woven together have been able to make this like really interesting product. And why is it interesting? Because it has some structure to it. It holds marrow elements there, but also it dissolves, and it's really like very inert. And it's 80% porous. And this is one of my favorite slides because you're seeing the kind of interwovenness between the PGA and the PLCA. And so PGA, let me go back. PGA PGA resorbs quickly, so it allows some porosity for marrow elements, whereas PLCL sticks around a little bit longer, so it leaves more of a scaffold there to retain what you want, your biology. So it's really like a biologic augmentation. So over time, as the PGA dissolves, there's more space for marrow elements, for cells to kind of integrate into the patch. And then the PLC sticks around a little bit longer, probably just enough for maturation and remodeling. Also, there's some pro-angiogenesis factors here, right? So you're getting some VEGF, some angiogenesis, you're getting blood cells coming in. And you're getting vascular integration. So what about proven results? I mean, it is a little bit on the early side, which is why I think this is a very interesting product, because it's looking really good, but it's early, so there's a lot of room for discovery here, which is great. So in vivo, awarded best paper, ASES and JSES 2023. It was an in vivo study that demonstrated much improved repair site histology. So if you look here, you see Sharpie's fiber, it looks perfect. You see Sharpie fibers and you see remodeling of the enthesis, which is what you want. They also have a prospective clinical outcome study on 30 patients with a 90% success rate, and they had 2-year MRI follow-up with 50% versus 7% re-tear rate, which is, I mean, it's pretty good. Well, you know, we should be skeptical about everything. So, and I'll present a case later, and we'll go over that. But for now, these are my indications. Medium and large rotator cuff tears, anything that is at risk for re-tear that I think I can fix, definitely. If I think I can't fix it, maybe not, but I'll have it on backup. Also, there's a role here for extensor mechanism repairs. Again, things where maybe you won't use it every single case, but maybe in cases where there's a risk of re-tear, like poor biology, smoker, older patient, low bone density, things like that. High-grade MCL tears, and I'll show a case of a distal MCL tear, because distal MCL tears heal less reliably than proximal ones, so you may want to augment your repair. And then MPFL reconstruction. I don't have a case on this, but MPFLs, we're going a lot towards onlays. So if you're doing an onlay at your patella, you're not drilling a hole, right? Because you're worried about fracture. Is there really healing there? Yeah, there may be scar, but there's an opportunity to improve the healing, I think. And they have a smaller kind of collagen patch that's thinner if you're worried about something being thick under the skin. So clinical considerations, again, when I'll use it is poor tissue quality. I use the Rohe score, and I have a slide on that. Revision cases, and high demand athletes too. People that want to get back, you want the best chance at a long-term outcome. You want to be able to leave the operating room saying, I did everything I could to make this patient better. So here's a case. This is a 50-year-old male with 3 months of right shoulder pain, worse after playing with his nephew. He cannot play pickleball. He works construction. He failed conservative. So he's not pseudoparalytic. He has forward flexion to 120, but he's weak. He's got Job's testing is positive. He's got some reduced external rotation, and he's not done well. And here's his imaging. So this is a large retracted tear. Got 2 centimeters of retraction. And I'll take you through these. So it is somewhat balanced. Like he probably has infra and subscap, but it's a large tear, and he's not doing well. And these progress, and we know the natural history of rotator cuff tears to get worse. And then it's large A to P too. So if we put this into our Rohe score, I'll just show it to you again, so it's good to look here on the sagittals and see the width. Oh, and then it's probably repairable, right? Because the tangent side is negative. There's not a lot of atrophy. There's no infra atrophy, but it's a big tear. It's a high risk of re-tear. So we put it into the Rohe score, which we're fortunate to have this score. It helps guide us on knowing what the healing rate will be. It looks at age, AP, and I put this in my note. Age, AP size, retraction, infraspinatus infiltration, fatty infiltration greater than 2, bone density, and level of work activity. And this patient has a 6. So at 6, it's about a 50% chance that he's going to heal, which really 50% is really not good. So I go 5 to 7, probably about 5 is my cutoff when I'm adding augmentation. Here's clinical cases. So pretty bare footprint there, debride the footprint. Drop your medial row anchors. Once you drop your medial row anchors, it's quite simple. There's a couple ways to do it. You just slide it down. There's no fancy mechanism. You're not, you have to have your PA in the back, passing multiple sutures through this thing. It's like not a big deal. You can either poke 2 holes where you have to measure the distance between your anchors, or I cut it in half and I just slide it down. I do one at a time. I drop my first anchor, I slide it down, I slide it down, I proceed with passing the sutures, then drop the second anchor, slide it down, pass the second set of sutures, and then start tying. And really, you kind of ignore it. And once you push it down, you have to kind of like, it'll flip a little bit maybe. You just have to like unflip it, push it down nicely, but it's not a big deal. And then hopefully you can get a good repair. So when you see this and you know you have a rhodium wick underneath and you're maintaining your marrow elements, you're pretty confident. So this is an early post-op patient, but I just thought it was a nice case, and he's doing quite well. I mean, at 3 months, 120. He used his snowblower this year in the Northeast. You had to do that this year. All right. Case 2. So here's a patella tendon. So this is an interesting example of when you might want to augment. A patella tendon, pretty high-level person. It's been 3 weeks, so it's, you're not sure. If you look at the tissue quality, most of these are in the setting of prior tendonitis, tendinopathy. And if you look, he's got changes in the tendon here. So these could be a little bit of risk of re-tear. So how do you do it? So there's 2 ways to do patella tendon repair, in my experience, which is transosseous, which we did for many years, and now we've gone to anchors. Actually, it looks like anchors are better. Re-tear rate in general is 8%. It's not crazy high, but yeah, you want to do anything you can for these patients. And probably anchors is probably less than 8%. So here's an example of how you would do that, which is what I'm doing now, which is adding anchors. It's open. Open surgery is, it's pretty straightforward. So you slide it down, and then you complete your repair. This is a tension slide technique with whip stitches. Yeah, and in both these cases, we've decorticated a bit to allow marrow elements to seep through, to be retained. And it's amazing how quickly, and you can see it in open more than scope because you have fluid in there. It's amazing how much fluid is retained within this wick. And then third case example, this is a 25-year-old male who had a big knee injury after falling off a bike. He underwent physical therapy. He got improved motion. At first, he was 0 to 80. But he had a 2B Lockman, and he had grade 2 opening at 0 and 30 to valgus, even though he was put in a brace. And so his MRI shows ACL tear, but on the right here, you can see the distal MCL avulsion. So distal MCLs do not heal as well. And if it's been like 6 weeks to 3 months, and this patient's still gapping to valgus, you probably want to consider fixing that. And it's probably early enough that you can. So the technique here is you do your ACL, and these are just examples from the lab, but you do your ACL, and then you can extend, no matter what your incision is, it's pretty close to the MCL insertion, or pretty close to the PES. You'll probably find it there. Occasionally, you'll have to just elevate the PES a little bit and retract it, and then you'll see your MCL fibers. For repairs, I do typically a double row repair. I think this is an example of just mattresses. So you just kind of spread out your anchors in the footprint there, pass down the rhodium wick. You can see here on the top left is a rhodium wick being passed down. They have different sizes, so they have a larger size and also a thinner size, which is really nice for this. Then you can go ahead and pass, now it's down, and you go ahead and pass those sutures with a free needle through the MCL, and then you can tie down a mattress, and you could take these and dunk these laterally for a lateral footprint for more coverage. All right, so a couple minutes. Thanks for listening. The key takeaways are mechanical repair alone may not be sufficient, right? So everybody's talking about increasing mechanical strength, right? There's been products here by a company that uses a lot of orange that has shown a new device that kind of suturing your tendon down, right? And it looks really good. But does that matter? I mean, yeah, it's maybe nice to have a good strength at time 0, but what we need is healing. We need healing by 3 months. So mechanical repair alone may not be sufficient. There's very encouraging early clinical experience. I will tell you anecdotally, the patients are, and really just not because I'm speaking for them, but really the patients are really happy. They seem to have decreased inflammation. I don't know if there's an anti-inflammatory property to this. There probably is. No one's observed inflammatory reaction, which another company has. It's applicable across many applications, and we've even heard about it in root repairs, which I think is great because if you think about it, the root does not want to heal. It's very important, so maybe we could slide it down and put it on the root. And addressing biology, again, we're not carpenters, we're gardeners. And at time 0 may improve long term. So thanks anyone. If anybody has questions, I'll take them. There's just one slide with all the studies that are out, so we hope to see more soon. But I'll be around.